Fluid and electrolyte management represents one of the most fundamental aspects of neonatal intensive care. This comprehensive review examines the unique physiological challenges of maintaining homeostasis in newborns across the gestational age spectrum. The principles discussed form the foundation of daily clinical decision-making in the NICU and remain among the most heavily tested topics in neonatal board examinations. This presentation addresses 6 critical competencies in neonatal fluid management. Understanding gestational age-dependent physiology provides the foundation for all therapeutic decisions. The ability to rapidly generate differential diagnoses for electrolyte abnormalities enables targeted interventions. Mastery of deficit calculations ensures precise replacement therapy. Management strategies for common disorders must account for the unique vulnerabilities of premature infants. Acid-base interpretation guides ventilatory and metabolic interventions, while glucose homeostasis prevents both immediate neurologic injury and long-term developmental sequelae. Finally, parenteral nutrition principles support growth when enteral feeding remains impossible. Neonatal fluid and electrolyte management requires individualized approaches that differ significantly from standardized adult protocols. Clinical decision-making must account for multiple patient-specific variables, including gestational age, birth weight, disease processes, and skin barrier maturity. For instance, extremely low birth weight infants with immature skin demonstrate substantially higher insensible water losses compared to term infants with intact skin barriers. Effective management necessitates daily clinical reassessment as neonates progress through distinct physiologic phases: the initial pre-diuretic period, followed by the diuretic phase, and subsequently the maintenance phase. Each phase requires corresponding adjustments to fluid and electrolyte therapy. Clinical vigilance must focus on avoiding overcorrection, as rapid alterations in serum sodium concentrations can precipitate neurologic complications, while excessive fluid restriction may compromise organ perfusion. The therapeutic objective involves maintaining appropriate fluid balance to prevent both deficits and excesses while ensuring adequate nutrition for growth and accounting for both measurable and insensible losses. This multifactorial approach distinguishes neonatal fluid management as a complex clinical discipline requiring continuous assessment and individualized therapeutic modifications rather than rigid protocol adherence. Neonatal physiology presents unique challenges for maintaining fluid and electrolyte homeostasis. The metabolic rate per kilogram in newborns exceeds that of adults by 2 to 3-fold, demanding greater substrate delivery. Paradoxically, renal function remains profoundly immature. Sodium excretion capacity reaches only 10% of older children's capabilities, while glomerular filtration rate measures 5 to 10 times lower than adult values. The proximal and distal tubules demonstrate decreased sodium reabsorption capacity, creating vulnerability to both sodium wasting and retention. Total body water distribution varies dramatically with gestational age, affecting volume of distribution for medications and electrolytes. These combined factors create a narrow therapeutic window where small errors in management precipitate significant morbidity. Understanding these physiologic constraints guides appropriate fluid prescription and monitoring strategies. Total body water composition undergoes dramatic shifts throughout gestation and early postnatal life. At 24 weeks gestation, water comprises 90% of body weight, with 65% residing in the extracellular compartment and only 25% intracellularly. This extreme extracellular predominance reflects immature cellular development and incomplete tissue differentiation. By 32 weeks, total body water decreases to 83%, with extracellular fluid dropping to 53%, while intracellular fluid increases to 30%. Term infants demonstrate 75 to 80% total body water, with extracellular and intracellular compartments approaching equilibrium at 45 and 35% respectively. By 1 year of age, the adult pattern emerges with 65% total body water, predominantly intracellular at 45% versus 20% extracellular. This gestational age-dependent distribution profoundly impacts fluid requirements, expected weight loss patterns, and susceptibility to fluid shifts. Body fluid distribution between intracellular and extracellular compartments maintains distinct compositions essential for cellular function. The intracellular compartment houses water and vital biomolecules within the cell membrane's protective barrier. Active transport mechanisms, including sodium-potassium ATPase pumps, maintain potassium as the predominant intracellular cation at concentrations of approximately 140 milliequivalents per liter. Intracellular pH regulation proves critical, as acidosis impairs enzymatic function and cellular metabolism. The extracellular compartment, characterized by sodium concentrations of 135 to 145 milliequivalents per liter and chloride as the primary anion, subdivides into intravascular and interstitial spaces. The intravascular space maintains circulating blood volume, while the interstitial space bathes tissues. Osmotic equilibrium between compartments prevents pathologic fluid shifts, though disease states frequently disrupt this delicate balance. Fluid movement between intravascular and interstitial spaces follows Starling's principles of capillary dynamics. When capillary hydrostatic pressure exceeds oncotic pressure, typically at the arteriolar end, filtration drives fluid into the interstitial space. Conversely, when oncotic pressure predominates at the venular end, reabsorption returns fluid to the intravascular compartment. The lymphatic system provides crucial drainage of excess interstitial fluid, preventing edema formation. Despite vastly different solute compositions between intracellular and extracellular compartments, osmolality must remain equal at approximately 290 milliosmoles per kilogram. Cell membrane permeability and energy-dependent transport systems maintain this equilibrium. Sodium-potassium ATPase pumps consume significant cellular energy, maintaining concentration gradients. Disruption of these mechanisms through hypoxia, sepsis, or metabolic derangements precipitates pathologic fluid shifts manifesting as cellular edema or dehydration. Birth triggers profound physiologic transitions in fluid homeostasis. Cessation of placental circulation initiates extracellular fluid compartment contraction through physiologic diuresis. This represents adaptation to terrestrial existence rather than pathology. Preterm infants typically lose 10 to 15% of birth weight, reflecting their higher initial extracellular fluid content. Term infants lose 5 to 10%. Regaining birth weight by 7 to 10 days. Extremely premature infants may require 2 to 3 weeks for weight recovery as they establish anabolic metabolism. The mechanism involves increased glomerular filtration following cord clamping, augmented by rising atrial natriuretic peptide levels. Initial negative sodium balance persists for 24 to 48 hours, as renal tubular reabsorption matures. Attempting to prevent this physiologic weight loss through excessive fluid administration increases risks of patent ductus arteriosus, intraventricular hemorrhage, and bronchopulmonary dysplasia. Understanding these normal transitions prevents inappropriate interventions. Very low birth weight infants experience predictable fluid management phases, requiring phase-specific strategies. The pre-diuretic phase spans the first 48 hours, characterized by oliguria and weight stability despite ongoing insensible losses. Management focuses on preventing hypoglycemia while allowing gradual extracellular fluid mobilization. Serum sodium trends guide fluid adjustments. The diuretic phase heralds improved renal function with increased urine output. Hypernatremia risk peaks during this transition as insensible losses continue while renal sodium excretion increases. Meticulous attention to intake, output, and weight changes prevents falling behind on fluid requirements. The post-diuretic maintenance phase begins once diuresis completes, typically by day 5 to 7. Goals shift towards supporting growth with adequate nutrition while maintaining homeostasis. Each phase demands different fluid volumes, electrolyte supplementation, and monitoring frequency. Initial fluid management goals prioritize facilitating normal physiologic adaptation while preventing complications. During the first 3 to 5 days, gradual extracellular fluid loss should proceed unimpeded, avoiding the temptation to maintain birth weight through excessive fluid administration. Electrolyte balance requires careful monitoring, particularly sodium and potassium. Circulating volume must support cardiovascular function. Hypotension, prolonged capillary refill, or metabolic acidosis indicate inadequate perfusion requiring intervention. Following successful transition, management shifts toward providing appropriate supplementation to maintain homeostasis while supporting growth. The overarching goal remains achieving appropriate weight loss patterns, 5 to 10% for term infants, 10 to 15% for preterm infants, reflecting normal extracellular fluid contraction rather than dehydration. Insensible water loss represents fluid evaporation through skin and respiratory tract that cannot be directly measured. Approximately 70% occurs transcutaneously, with 30% through pulmonary evaporation. Calculation requires meticulous tracking. Insensible water loss equals fluid intake minus urine output plus weight change. This calculation assumes minimal stool losses and stable metabolic state. Expected insensible losses vary inversely with birth weight and gestational age. Infants weighing 750 to 1,000 grams lose approximately 80 milliliters per kilogram per day through insensible routes during the first week. Those weighing 1,001 to 1,250 grams lose 50 milliliters per kilogram per day. Infants between 1,251 and 1,500 grams experience 45 milliliters per kilogram per day losses. Birth weights exceeding 1,500 grams correlate with 25 milliliters per kilogram per day insensible losses. These values assume neutral thermal environment in humidified incubators. Radiant warmers, phototherapy, or ambient temperature elevation significantly increase these baseline losses. Multiple factors modulate insensible water losses, requiring individualized fluid prescriptions. Gestational age and birth weight demonstrate the strongest inverse correlation. The most immature infants experience the highest losses due to immature skin barrier function. Respiratory distress increases minute ventilation and pulmonary evaporative losses. Ambient temperatures exceeding the neutral thermal environment trigger sweating and increased evaporation. Fever elevates metabolic rate and respiratory losses. Radiant warmers can double insensible losses compared to humidified incubators. Phototherapy's effect remains controversial. Newer LED lights generate less heat than traditional systems. Increased motor activity and tachypnea augment losses. Skin breakdown or congenital defects like gastroschisis or myelomeningocele create direct evaporative surfaces. Conversely, heat shields or double-walled incubators create favorable microenvironments. Plastic blankets reduce convective losses. Clothing provides barrier protection. High relative humidity approaching 100% minimizes the vapor pressure gradient driving evaporation. Topical emollients enhance skin barrier function. Prenatal steroids accelerate skin maturation, reducing baseline insensible losses. Comprehensive assessment begins with maternal history, which directly impacts neonatal fluid status at delivery. Maternal oxytocin administration, diuretic therapy, or hypotonic intravenous fluids predispose to neonatal hyponatremia through placental equilibration. Antenatal corticosteroids confer multiple benefits. Accelerated skin maturation reduces insensible losses, while enhanced renal tubular function decreases non-oliguric hyperkalemia risk in extremely premature infants. Oligohydramnios suggests fetal renal abnormalities warranting close monitoring. Perinatal hypoxia or asphyxia may precipitate acute tubular necrosis with oliguria. Physical assessment centers on daily weights, the most sensitive indicator of fluid balance. Weight changes directly reflect total body water alterations. Traditional signs like decreased skin turgor, sunken fontanelle, or dry mucous membranes represent late findings indicating significant dehydration. Edema similarly indicates established fluid overload. Early detection through weight monitoring enables intervention before clinical signs manifest. Vital sign interpretation requires understanding neonatal compensatory mechanisms. Tachycardia represents a nonspecific response occurring with both extracellular fluid excess, causing congestive symptoms, and hypovolemia triggering compensatory mechanisms. Capillary refill provides more specific information when assessed centrally on forehead or sternum, with normal values under 3 seconds. Peripheral perfusion varies with temperature and activity. blood pressure represents a late indicator of hypovolemia due to robust neonatal compensatory mechanisms. Significant volume depletion occurs before hypotension manifests. Accurate intake and output documentation proves essential, including often overlooked medication flushes that may contribute 20 to 30 milliliters per kilogram daily in extremely low birth weight infants. Normal urine output after 24 hours ranges from 1 to 3 milliliters per kilogram per hour. Extremely low birth weight infants present unique challenges. Immature tubular function may maintain urine output despite significant extracellular fluid depletion. Normal stool losses approximate 5 to 10 milliliters per kilogram per day, but increase substantially with diarrhea or ostomy output. Laboratory assessment guides fluid and electrolyte management, but requires appropriate timing and interpretation. Initial laboratory values obtained before 10 to 12 hours reflect maternal status through placental equilibration rather than neonatal physiology. Serum electrolytes, blood urea nitrogen, and creatinine provide fundamental data. Glucose monitoring prevents both hypoglycemia and hyperglycemia. Acid-base status offers indirect evidence of perfusion adequacy. Metabolic acidosis suggests inadequate circulating volume. Extremely low birth weight infants require frequent monitoring, every 4 to 6 hours, during the first days due to rapidly changing physiology and narrow therapeutic windows. Urine studies provide additional diagnostic information. Specific gravity reflects concentrating ability, though premature infants demonstrate limited range. Fractional excretion of sodium calculations help differentiate pre-renal from intrinsic renal dysfunction. Values below 1% suggest pre-renal etiology with intact tubular function. Values exceeding 2.5% indicate acute kidney injury, though infants under 32 weeks gestation normally demonstrate elevated fractional excretion due to tubular immaturity. The inverse relationship between birth weight and initial fluid requirements reflects fundamental physiological differences across gestational ages. Extremely preterm infants demonstrate dramatically higher insensible water losses due to immature skin barrier function, increased surface area to volume ratios, and elevated metabolic rates. Their underdeveloped renal concentrating ability further compounds fluid management complexity. The temporal progression across the first 72 hours mirrors predictable physiological transitions. During the immediate postnatal period, conservative fluid administration prevents interference with essential physiologic weight loss while maintaining adequate intravascular volume. As infants transition through the pre-diuretic phase toward established diuresis, fluid requirements increase correspondingly to support improving renal function and emerging nutritional needs. The convergence of fluid requirements after 48 hours reflects the shift from purely maintenance hydration toward nutritional support. At this stage, enteral feeding introduction begins influencing total fluid calculations, while ongoing insensible losses continue requiring careful monitoring and adjustment. These guidelines provide starting points for individualized management. Clinical assessment must continuously incorporate factors such as ambient humidity, phototherapy exposure, respiratory support requirements, and individual patient responses. Serial weight measurements, electrolyte monitoring, and urine output assessment guide necessary modifications to these foundational recommendations. Maintenance fluid calculations incorporate multiple variables beyond simple replacement. The formula includes insensible water loss, plus sensible losses through urine and stool, plus additional volume for growth. Requirements typically increase 20 to 40 milliliters per kilogram per day over the first week as renal function matures and nutritional needs escalate. However, fluid administration carries significant risks in premature infants. Excessive volume increases patent ductus arteriosus flow, potentially precipitating congestive heart failure. Rapid fluid shifts may contribute to intraventricular hemorrhage pathogenesis. Some evidence links aggressive fluid administration to necrotizing enterocolitis, though causation remains debated. After completing the diuretic phase, a useful clinical guideline suggests intake should approximate 2/3 of measured output, accounting for ongoing insensible losses. This relationship helps prevent both dehydration and fluid overload while supporting appropriate growth. Electrolyte supplementation timing reflects physiologic transitions and safety considerations. No sodium or potassium supplementation should occur during the first 24 hours. Early sodium administration opposes physiologic extracellular fluid contraction, while potassium risks hyperkalemia before establishing adequate renal function. After 24 to 48 hours, sodium requirements range from 2 to 3 milliequivalents per kilogram per day. The anion choice matters: chloride for routine replacement, acetate for mild metabolic acidosis providing buffer, or phosphate when addressing hypophosphatemia. Extremely preterm infants may require 3 to 5 milliequivalents per kilogram per day during the postdiuretic phase due to elevated renal losses. Potassium supplementation begins only after confirming urine output exceeding 1 milliliter per kilogram per hour. Initial doses of 1 to 2 milliequivalents per kilogram per day may increase to 3 to 4 milliequivalents as anabolism accelerates. Calcium requirements begin immediately at 20 to 60 milligrams per kilogram per day of elemental calcium, increasing to 60 to 80 milligrams per kilogram per day to support bone mineralization and cellular function. Dehydration beyond expected physiologic weight loss requires prompt recognition and intervention. Common causes include uncounted losses through chest tubes or gastric drainage that escape routine measurement. Third space losses complicate conditions like necrotizing enterocolitis, sepsis, gastroschisis, or omphalocele. As fluid shifts into interstitial spaces or peritoneal cavity, diagnosis relies primarily on weight loss exceeding anticipated patterns, greater than 10% in term infants or 15% in preterm infants. Decreased urine output below 1 milliliter per kilogram per hour with increased specific gravity suggests renal conservation. Tachycardia and hypotension represent late findings after compensatory mechanisms fail. Metabolic acidosis indicates inadequate tissue perfusion. Blood urea nitrogen elevation reflects prerenal azotemia. Critically, infants under 32 weeks gestation may maintain urine output despite significant deficits due to tubular immaturity. Management involves calculating and correcting the fluid deficit while adjusting maintenance requirements upward. Symptomatic dehydration with cardiovascular compromise warrants immediate normal saline bolus of 10 milliliters per kilogram over 30 minutes. Edema represents pathologic fluid accumulation in interstitial spaces, requiring different management than simple fluid overload. Excessive isotonic fluid administration remains the most common cause, particularly when attempting to prevent physiologic weight loss. Heart failure from patent ductus arteriosus or myocardial dysfunction causes venous congestion and fluid extravasation. Sepsis increases capillary permeability, allowing intravascular fluid to leak into tissues. Long-term paralytic use eliminates muscle pump activity, promoting dependent edema. Diagnosis begins with weight gain exceeding expected patterns. Periorbital edema appears early due to loose connective tissue. Extremity edema follows, with pitting characteristics indicating interstitial fluid accumulation. Hepatomegaly suggests venous congestion. Management strategies depend on serum sodium levels. With normal or elevated sodium, restrict total sodium intake to promote natriuresis. With hyponatremia, restrict free water to correct dilutional effects. Throughout treatment, maintain adequate intravascular volume to preserve organ perfusion despite total body fluid excess. Sodium serves as the primary determinant of extracellular fluid tonicity, controlling water distribution between compartments. Normal serum concentrations range from 135 to 145 milliequivalents per liter, with tight regulation essential for cellular function. Daily requirements vary from 2 to 4 milliequivalents per kilogram, though extremely preterm infants may need higher amounts due to immature tubular reabsorption. Hypernatremia creates hyperosmolar extracellular fluid, drawing water from cells and causing cellular dehydration. Neural tissue proves particularly vulnerable, with acute shrinkage potentially causing vascular rupture and intracranial hemorrhage. Conversely, hyponatremia produces hypoosmolar extracellular fluid, driving water intracellularly and causing cellular edema. Brain cells swell within the rigid cranium, potentially causing seizures, altered consciousness, or herniation. Understanding these osmotic principles guides therapeutic interventions and explains why correction must proceed gradually to allow cellular adaptation. Hyponatremia below 130 milliequivalents per liter requires systematic evaluation to determine etiology and guide treatment. Factitious hyponatremia from severe hyperlipidemia represents a laboratory artifact not requiring treatment. True hyponatremia divides into volume depletion versus dilutional categories. Volume depletion causes include diuretic therapy, osmotic diuresis from glucoseuria, or renal immaturity in premature infants. Congenital adrenal hyperplasia impairs sodium retention through mineralocorticoid deficiency. Gastrointestinal losses through diarrhea or high ostomy output deplete both sodium and water. Third spacing in necrotizing enterocolitis sequesters sodium-containing fluid in intestinal walls and peritoneum. Dilutional hyponatremia results from excess free water administration or syndrome of inappropriate antidiuretic hormone secretion. SIADH triggers include pain, opiates, intraventricular hemorrhage, asphyxia, meningitis, sepsis, hypotension, and pneumothorax. Severe hyponatremia below 120 milliequivalents per liter risks seizures and coma requiring emergency intervention. Identifying the underlying mechanism directs appropriate therapy. Hyponatremia management depends critically on presence of neurologic symptoms and volume status. Emergency intervention for seizures or sodium below 125 milliequivalents per liter begins with 3% hypertonic saline at 1 to 3 milliliters per kilogram over 15 minutes. This rapidly raises serum sodium by approximately 3 to 5 milliequivalents per liter, often terminating seizures. Continue with slower infusion while monitoring for fluid overload and pulmonary edema. For volume depletion without emergency symptoms, calculate the sodium deficit using the formula desired sodium minus actual sodium multiplied by 0.6, representing total body water fraction multiplied by weight in kilograms. For a 1.5 kilogram infant with sodium of 120, targeting 130, 10 milliequivalents per liter deficit times 0.6 times 1.5 kilograms equals 9 milliequivalents total deficit. Replace half this deficit over 6 to 12 hours to avoid rapid shifts risking central pontine myelinolysis. Don't forget ongoing maintenance sodium requirements. Syndrome of inappropriate ADH with normal volume requires fluid restriction unless severe symptoms mandate hypertonic saline. Volume excess hyponatremia needs treatment of underlying causes like heart failure plus free water restriction. Hypernatremia exceeding 150 milliequivalents per liter occurs through two distinct mechanisms, requiring different management approaches. With normal or deficient extracellular fluid volume, excessive water losses exceed sodium losses. Premature infants experience elevated renal free water losses through immature concentrating ability. Insensible losses through immature skin barrier may reach 100 milliliters per kilogram per day in extremely low birth weight infants. Skin sloughing from extreme prematurity or collodion baby syndrome creates direct evaporative surfaces. Central diabetes insipidus, following intraventricular hemorrhage, impairs antidiuretic hormone secretion. Alternatively, hypernatremia with extracellular fluid excess results from excessive isotonic or hypertonic fluid administration exceeding renal excretion capacity, particularly with decreased cardiac output impairing renal perfusion. Sodium levels exceeding 160 milliequivalents per liter risk permanent central nervous system damage through cellular dehydration and vascular injury. Trends matter more than isolated values. Rapidly rising sodium indicates ongoing losses requiring aggressive intervention. Clinical findings include weight loss, tachycardia, hypotension, and metabolic acidosis from poor perfusion. Hypernatremia correction requires gradual approach to prevent catastrophic cerebral edema. With normal or deficient volume, increase free water administration through hypotonic fluids. Reduce serum sodium no faster than 0.5 to 1 milliequivalent per liter per hour, targeting full correction over 12 to 48 hours, depending on chronicity. In very low birth weight infants, hypernatremia typically reflects free water deficit rather than sodium excess. Replacing water without restricting sodium prevents iatrogenic hyponatremia. Calculate free water deficit: 4 milliliters per kilogram for each milliequivalent per liter above 145. With extracellular fluid volume excess, restrict sodium administration while maintaining adequate free water. Throughout correction, balance competing risks. Excessively rapid correction causes rebound cerebral edema as adapted cells swell, while prolonged hypernatremia perpetuates cellular dehydration and metabolic dysfunction. Serial neurologic assessments during correction detect early signs of cerebral edema. Potassium represents the predominant intracellular cation, with 98% residing intracellularly at concentrations near 140 milliequivalents per liter. Serum levels between 3.5 and 5.0 milliequivalents per liter reflect a tiny fraction of total body stores. Acid-base status profoundly affects distribution. Each 0.1 pH unit increase drives 0.6 milliequivalents per liter potassium intracellularly as hydrogen ions exit cells. Conversely, acidosis shifts potassium extracellularly, potentially masking total body depletion. Normal requirements range from 1 to 2 milliequivalents per kilogram per day, but supplementation requires established urine output exceeding 1 milliliter per kilogram per hour. Both gastrointestinal tract and kidneys participate in excretion, with renal handling predominating. Understanding these distribution dynamics explains why serum levels poorly reflect total body stores, and why pH correction dramatically alters serum concentrations. Hypokalemia, below 3.5 milliequivalents per liter, commonly results from inadequate intake relative to ongoing losses. Loop diuretics, like furosemide, inhibit sodium-potassium chloride cotransporters, increasing urinary potassium excretion. Gastrointestinal losses through diarrhea or high ostomy output deplete potassium-rich intestinal fluids. Hypomagnesemia impairs distal tubular potassium handling, making correction impossible without magnesium repletion. Clinical manifestations reflect potassium's role in cellular electrical activity. Cardiac arrhythmias range from premature contractions to dangerous ventricular rhythms. Electrocardiogram shows decreased T-wave amplitude and ST segment depression. Generalized muscle weakness progresses to paralysis in severe cases. Intestinal smooth muscle dysfunction causes ileus. Renal concentrating defects produce polyuria, worsening potassium losses. Severe depletion alters consciousness, potentially causing coma. Emergency correction for symptomatic hypokalemia uses 0.5 to 1 milliequivalent per kilogram over 30 to 60 minutes with continuous cardiac monitoring. Routine replacement over 12 to 24 hours follows deficit calculation, desired minus actual potassium multiplied by 0.3, representing extracellular distribution multiplied by weight. Always verify adequate magnesium levels before attempting potassium correction. Hyperkalemia exceeding 5.5 milliequivalents per liter threatens cardiac conduction, requiring systematic evaluation. The most common cause remains hemolyzed blood samples from traumatic draws. Always repeat with careful venous sampling before treatment. True hyperkalemia results from increased release, decreased excretion, or transcellular shifts. Acidosis with tissue damage shifts intracellular potassium outward, while damaged cells release their contents. Cephalomatomas and other hemorrhages provide large potassium loads during red cell breakdown. Hemolysis from any cause floods extracellular space with potassium. Hypothermia impairs cellular pumps maintaining gradients. Asphyxia and ischemia damage cell membranes, releasing intracellular contents. Acute kidney injury prevents excretion. Adrenal insufficiency lacks mineralocorticoid effects promoting excretion. Intraventricular hemorrhage combines tissue damage with potential SIADH. Extremely low birth weight infants experience non-oliguric hyperkalemia during the first days from immature distal tubular function. Iatrogenic causes include excessive supplementation or concentrated flushes. Immediate electrocardiogram assessment guides urgency of intervention. with changes typically appearing above 6 milliequivalents per liter. Hyperkalemia presents a diagnostic challenge because patients may appear asymptomatic initially despite life-threatening serum levels. Clinical manifestations center on cardiovascular instability, ranging from bradyarrhythmias and tachyarrhythmias to complete cardiovascular collapse. This unpredictable presentation makes electrocardiographic monitoring essential for risk assessment. The electrocardiogram provides the most reliable indicator of cardiac toxicity, with changes progressing predictably as potassium levels rise. At 6.5 milliequivalents per liter, tall peaked T waves emerge as the earliest sign, reflecting accelerated cardiac repolarization. As levels increase from 6.5 to 8, conduction abnormalities develop progressively. PR intervals prolong, QRS complexes widen, and P waves eventually disappear. When potassium exceeds 8 milliequivalents per liter, the situation becomes critically dangerous. QRS complexes become increasingly bizarre and distorted, signaling imminent risk of ventricular tachycardia, ventricular fibrillation, or asystole. The key clinical principle is that any ECG abnormality suggesting hyperkalemia demands immediate intervention, regardless of the absolute potassium level, as individual cardiac sensitivity varies significantly among patients. The CBIG-2 protocol provides systematic hyperkalemia management addressing 3 goals: cardiac protection, potassium redistribution, and elimination. First, remove all exogenous potassium sources, including intravenous fluids and medications. Stage 1 stabilizes cardiac conductive tissue using calcium gluconate, 100 mg per kilogram, equivalent to 1 to 2 milliliters per kilogram of 10% solution, infused over 15 to 30 minutes. Calcium antagonizes potassium's membrane effects without changing serum levels. Administer normal saline bolus if concurrent hyponatremia exists. Stage 2 shifts potassium intracellularly through multiple mechanisms. Sodium bicarbonate 1 to 2 milliequivalents per kilogram alkalinizes blood, driving potassium into cells. Insulin 0.05 to 0.1 units per kilogram activates sodium-potassium pumps, accompanied by dextrose 10% water at 2 to 3 milliliters per kilogram, preventing hypoglycemia. Flush insulin tubing before administration as plastic binds insulin. Beta-2 agonists like albuterol at 0.1 to 0.5 milligrams per kilogram provide additional intracellular shift. Stage 3 eliminates potassium from the body. Furosemide 1 to 2 milligrams per kilogram enhances renal excretion, if adequate function exists. Kayexalate poses bowel ischemia risk in extremely low birth weight infants. Reserve peritoneal dialysis or exchange transfusion for refractory cases. Calcium serves multiple critical physiologic functions beyond bone mineralization. The coagulation cascade requires calcium as a cofactor for multiple steps. Neuromuscular excitability depends on calcium's role in action potential propagation and neurotransmitter release. Cell membrane integrity and selective permeability require adequate calcium. Numerous intracellular enzymes utilize calcium as a cofactor. Parathyroid hormone increases serum calcium through bone resorption, enhanced intestinal absorption, and renal retention. Calcitriol, the active form of vitamin D, primarily enhances intestinal absorption. Normal total serum calcium ranges from 8.5 to 10.2 milligrams per deciliter, though protein binding affects interpretation. Ionized calcium between 4.4 and 5.3 milligrams per deciliter represents the physiologically active fraction, making it the preferred measurement in critically ill neonates. Hypocalcemia frequently complicates the early neonatal period through multiple mechanisms. Abrupt cessation of placental calcium transfer at delivered challenges neonatal homeostatic mechanisms. Parathyroid hormone secretion may lag for 48 to 72 hours, particularly in premature infants. DeGeorge sequence includes parathyroid hypoplasia, causing profound hypocalcemia. Maternal hyperparathyroidism suppresses fetal parathyroid development through chronic hypercalcemia exposure. Hypomagnesemia impairs both parathyroid hormone secretion and end organ responsiveness. Vitamin D deficiency, increasingly common with limited sun exposure, reduces intestinal absorption. Alkalosis and bicarbonate administration increase protein binding, reducing ionized fraction. Shock and sepsis impair multiple regulatory mechanisms. Phototherapy may alter vitamin D metabolism. High phosphate intake, particularly from cow's milk, complexes with calcium. Definition varies with measurement method. Total calcium below 7 mg per deciliter or ionized calcium below 4 mg per deciliter, equivalent to 0.8 to 1 millimole per liter. Ionized levels provide superior accuracy in hypoalbuminemic states. Hypocalcemia produces neuromuscular irritability, progressing to tetany and seizures. Early signs include jitteriness, irritability, and fine twitching, easily mistaken for normal newborn behavior. Increased extensor tone manifests as opus the tonus in severe cases. Clonus and hyperreflexia indicate heightened neuromuscular excitability. Stridor or larynx spasm reflects laryngeal muscle tetany, a medical emergency. Seizures typically present as focal motor activity, progressing to generalized convulsions. Management begins with checking magnesium levels. Correction proves futile without adequate magnesium. For acute symptomatic hypocalcemia with seizures or cardiac dysfunction, administer calcium gluconate 10% solution at 1 to 2 milliliters per kilogram intravenously over 10 to 15 minutes with cardiac monitoring. Rapid administration risks bradycardia or asystole. Calcium gluconate syrup provides enteral supplementation for stable infants at 100 to 200 milligrams per kilogram per day of elemental calcium. High-risk infants benefit from prophylactic intravenous supplementation at 60 to 80 milligrams per kilogram per day elemental calcium, preventing symptomatic episodes. Calcium administration carries unique risks, requiring meticulous attention to technique. Rapid infusion causes profound bradycardia progressing to asystole through direct myocardial depression. Always infuse over at least 10 minutes with continuous monitoring. Umbilical venous catheter malposition with hepatic infusion causes focal hepatic necrosis from calcium's caustic effects. Never administer calcium through umbilical arterial catheters. Direct arterial infusion causes vasospasm, potentially producing intestinal necrosis through mesenteric ischemia. Calcium precipitates immediately with bicarbonate, creating particulate emboli. Never mix in the same line and flush thoroughly between medications. Peripheral extravasation causes severe tissue necrosis with calcification, requiring plastic surgery consultation. The high osmolality and alkaline pH of calcium solutions mandates central access for continuous infusions. These complications underscore the need for careful administration, despite calcium's essential role. Hypercalcemia, though less common than hypocalcemia, carries significant morbidity. Total calcium exceeding 11 milligrams per deciliter or ionized calcium above 1.45 millimoles per liter defines hypercalcemia. Severe elevation above 16 milligrams per deciliter total or 1.8 millimoles per liter ionized constitutes an emergency, risking cardiac arrhythmias and renal failure. Iatrogenic causes predominate, including excessive vitamin D supplementation or overcorrection of hypocalcemia. Inadequate phosphorus in parenteral nutrition allows unopposed calcium absorption and bone resorption. Primary hyperparathyroidism rarely presents neonatally, but maternal hypoparathyroidism may trigger reactive neonatal hyperparathyroidism. Hyperthyroidism accelerates bone turnover. Williams syndrome includes hypercalcemia through unclear mechanisms. Hypophosphatasia prevents normal bone mineralization, elevating serum calcium. Thiazide diuretics enhance distal tubular calcium reabsorption. Subcutaneous fat necrosis following traumatic delivery releases calcium during resolution. Hypercalcemia produces nonspecific symptoms easily attributed to other neonatal conditions. Poor feeding and emesis reflect gastrointestinal dysmotility. Lethargy alternating with irritability indicates central nervous system effects. Constipation results from smooth muscle dysfunction. Polyuria occurs through nephrogenic diabetes insipidus mechanisms, as hypercalcemia impairs concentrating ability. Hypotonia and encephalopathy develop with severe elevations. Chronic hypercalcemia causes hepatosplenomegaly, anemia from myelofibrosis, and metastatic skeletal calcifications. Emergency management begins with volume expansion using normal saline at twice maintenance rates. diluting calcium while enhancing renal excretion. Furosemide at 1 to 2 mg per kilogram promotes calciuresis but requires adequate hydration first. Hypophosphatemia necessitates phosphate supplementation to allow bone deposition. Glucocorticoids treat hypervitaminosis D by opposing vitamin D effects. Parenteral nutrition-related hypercalcemia responds to adjusting calcium-phosphorus ratios. Maintain 1.7 to 1 by weight or 1.3 to 1 molar ratios. Magnesium plays crucial roles in enzymatic function and neuromuscular stability. Normal levels range from 1.5 to 2.5 milligrams per deciliter, with supplementation at 0.25 to 0.5 milliequivalents per kilogram per day. Hypomagnesemia, below 1.6 milligrams per deciliter, though uncommon, presents with apnea and poor tone mimicking hypocalcemia. Treatment uses magnesium sulfate supplementation, remembering that calcium correction fails without adequate magnesium. Hypermagnesemia, exceeding 3 milligrams per deciliter, typically results from maternal magnesium therapy for preeclampsia or tocolysis. Manifestations include respiratory depression, hypotonia, and delayed meconium passage. Supportive care suffices, as renal excretion normalizes levels within 48 to 72 hours. Chloride, the major extracellular anion, normally ranges from 97 to 110 milliequivalents per liter. Hypochloremia usually parallels hyponatremia but independently contributes to metabolic alkalosis through increased bicarbonate reabsorption. Combined sodium and chloride deficiency significantly impairs growth. Hyperchloremia rarely occurs except through iatrogenic administration of excessive normal saline or hyperalimentation solutions. Acid-base homeostasis maintains pH within the narrow range of 7.35 to 7.45 required for enzymatic function. The Henderson-Hasselbalch equation describes the relationship pH equals 6.1 plus log of bicarbonate divided by 0.03 times partial pressure of carbon dioxide. An inverse relationship exists between pH and hydrogen ion concentration. Each 0.1 pH unit decrease doubles hydrogen ion concentration. Three systems provide regulation. Chemical buffers, including bicarbonate, phosphate, and proteins, provide immediate response. Pulmonary elimination of carbon dioxide adjusts within minutes through respiratory rate changes. Renal regulation of hydrogen ion secretion and bicarbonate reabsorption provides definitive correction over hours to days. Understanding these mechanisms enables interpretation of blood gas results and guides therapeutic interventions. Respiratory acid-base disorders reflect primary alterations in carbon dioxide elimination through ventilation. Respiratory acidosis presents with pH below 7.35 and partial pressure of carbon dioxide exceeding 45 millimeters mercury from inadequate alveolar ventilation. Common causes include respiratory distress syndrome in premature infants, neurologic compromise affecting respiratory drive, and medications like opioids suppressing ventilation. Chronic respiratory acidosis triggers renal compensation through bicarbonate retention. Respiratory alkalosis shows pH above 7.45 with carbon dioxide below 35 millimeters mercury from alveolar hyperventilation. Mechanical overventilation remains the most common cause in neonates, though spontaneous tachypnea from pain, anxiety, or central nervous system irritation contributes. Metabolic compensation through decreased bicarbonate reabsorption requires 24 to 48 hours. Recognition enables appropriate ventilator adjustments rather than metabolic interventions. Metabolic acidosis indicates primary bicarbonate deficiency or acid excess, presenting with pH below 7.35 and bicarbonate below 22 milliequivalents per liter. Carbon dioxide levels below 20 on electrolyte panels reflect bicarbonate. Multiple etiologies exist. Hypoxia produces lactic acidosis through anaerobic metabolism. Immature renal function limits acid excretion. Diarrhea causes bicarbonate loss in stool. The anion gap calculation. Sodium minus chloride plus bicarbonate differentiates causes. Normal gap of 8 to 15, up to 18 in preterm infants, indicates bicarbonate losses or renal tubular acidosis. Increased gap exceeding 15 suggests unmeasured anions, lactate in hypoxia, organic acids in inborn errors, retained acids in renal failure, or exogenous toxins. Respiratory compensation through hyperventilation begins within minutes. Metabolic alkalosis shows pH above 7.45 with bicarbonate exceeding 26 milliequivalents per liter. Vomiting causes hydrogen ion loss. Loop diuretics promote hydrogen secretion. Excessive alkali administration through bicarbonate or acetate contributes. Respiratory compensation through hypoventilation has limits. Understanding correction versus compensation guides appropriate interventions for acid-base disorders. Correction addresses the primary problem, adjusting ventilator settings for respiratory acidosis or improving perfusion for lactic acidosis. Compensation represents the body's attempt to normalize pH through the unaffected system. Chronic respiratory acidosis triggers renal bicarbonate retention, while metabolic acidosis stimulates hyperventilation. Management prioritizes treating underlying causes rather than normalizing numbers. Respiratory disorders require ventilation adjustments, increasing rate or tidal volume for acidosis, decreasing for alkalosis. Metabolic acidosis often reflects circulatory insufficiency, requiring volume expansion or inotropic support. Bicarbonate administration rarely helps unless pH falls below 7.1. When administering bicarbonate, monitor potassium carefully. Alkalinization drives potassium intracellularly, potentially precipitating dangerous hypokalemia. Allow compensation time to reverse after correcting primary disorders. Antidiuretic hormone disorders profoundly affect fluid balance through altered renal water handling. Syndrome of inappropriate ADH secretion causes water retention despite normal or increased volume status. Common triggers include perinatal depression, intraventricular hemorrhage disrupting hypothalamic pituitary axis, sepsis, hypotension, meningitis, and pneumothorax. Diagnosis requires demonstrating oliguria below 1 milliliter per kilogram per hour, weight gain, hyponatremia, low serum osmolality below 280 milliosmoles per kilogram, and inappropriately concentrated urine above serum osmolality. Treatment involves free water restriction to 2/3 maintenance, sodium supplementation for symptomatic hyponatremia, and occasionally furosemide to promote free water excretion. Diabetes insipidus produces opposite effects through ADH deficiency or resistance. Central diabetes insipidus from pituitary dysfunction may follow severe intraventricular hemorrhage. Nephrogenic diabetes insipidus reflects tubular unresponsiveness. Both produce polyuria exceeding 5 milliliters per kilogram per hour, hypernatremia, elevated serum osmolality, and dilute urine. Treatment requires careful hydration matching losses, electrolyte replacement, and paradoxically, thiazide diuretics, which enhance proximal water reabsorption. Hypoxic ischemic encephalopathy creates multiple fluid management challenges through combined central nervous system and renal effects. Hypoxic injury triggers inappropriate ADH secretion while simultaneously damaging renal tubules. Initial management requires fluid restriction below 60 milliliters per kilogram per day, balancing SIADH treatment against maintaining adequate perfusion. Serial head ultrasounds monitor for cerebral edema, requiring further restriction. Withhold potassium supplementation until urine output exceeds 1 milliliter per kilogram per hour, preventing dangerous hyperkalemia. The clinical course typically progresses through phases. Initial oliguria lasting 24 to 48 hours, followed by polyuric recovery as tubular function improves. During oliguria, maintain strict fluid restriction while monitoring for volume depletion. The polyuric phase requires careful replacement of measured losses to prevent dehydration and electrolyte derangements. Recovery may take weeks with persistent concentrating defects. Respiratory conditions significantly impact fluid management strategies. Respiratory distress syndrome shows no improvement until extracellular fluid mobilization begins. The onset of diuresis often heralds lung improvement. Fluid management requires individualization based on severity and response. Patent ductus arteriosus management remains controversial. While fluid restriction theoretically reduces ductal flow, evidence for clinical benefit remains limited. Medical management with indomethacin or ibuprofen requires careful monitoring. Both cause renal vasoconstriction, potentially precipitating acute kidney injury. Acetaminophen avoids renal effects, but efficacy remains under investigation. Bronchopulmonary dysplasia creates competing demands, fluid sensitivity necessitating restriction to 120 to 125 milliliters per kilogram per day, while high caloric needs for growth require concentrated nutrition. Chronic furosemide use depletes calcium and phosphorus, increasing osteopenia risk. Nephrocalcinosis develops in up to 60% of chronically treated infants. Consider potassium-sparing diuretics or intermittent rather than daily furosemide to minimize complications. Multiple clinical scenarios require specialized fluid management approaches. Early onset hyponatremia during the first few days typically reflects excessive free water administration opposing physiologic contraction. Late onset hyponatremia after the first week suggests ongoing losses or SIADH. Management depends critically on volume assessment. Oliguria below 1 milliliter per kilogram per hour demands systematic evaluation. Pre-renal causes from inadequate perfusion respond to volume expansion. Parenchymal injury from acute tubular necrosis requires supportive care. Post-renal obstruction needs urgent drainage. Acute kidney injury profoundly affects all aspects of fluid and electrolyte balance, occurring with or without oliguria. Non-oliguric acute kidney injury maintains urine output but loses regulatory capacity. Gastrointestinal pathology creates multiple derangements. Surgical conditions increase third space losses. Necrotizing enterocolitis causes massive fluid shifts into intestinal walls. Diarrhea depletes bicarbonate, causing normal gap acidosis. Vomiting loses hydrogen ions, producing hypochloremic alkalosis. Diuretic therapy requires understanding site-specific mechanisms and monitoring for predictable complications. Thiazides, including chlorothiazide and hydrochlorothiazide, inhibit sodium chloride cotransporter in the distal convoluted tubule. While less potent than loop diuretics, they effectively treat mild fluid overload. Monitor for hyponatremia and hypokalemia from enhanced distal delivery. Unique among diuretics, thiazides decrease calcium excretion, potentially beneficial in chronic lung disease. Spironolactone competitively inhibits aldosterone at collecting duct receptors, promoting sodium excretion while retaining potassium. The potassium-sparing effect prevents dangerous hypokalemia, but mandates monitoring for hyperkalemia, particularly with concurrent angiotensin-converting enzyme inhibitors. Furosemide powerfully inhibits the sodium-potassium chloride cotransporter in the thick ascending loop of Henle, where 25% of sodium reabsorption occurs. This produces marked diuresis but depletes multiple electrolytes. Chronic use causes hypocalciuria with secondary hyperparathyroidism, contributing to osteopenia of prematurity. Nephrocalcinosis develops from calcium phosphate precipitation in alkaline urine. Monitor electrolytes, calcium, phosphorus, and renal ultrasounds with chronic therapy. Fetal glucose metabolism depends entirely on maternal supply through facilitated diffusion across the placenta. Fetal glucose levels equilibrate at approximately 70% of maternal values due to placental glucose consumption and fetal utilization. Despite possessing all gluconeogenic enzymes, the fetus produces minimal endogenous glucose. High insulin levels and abundant exogenous supply suppress production. During extreme maternal starvation, the fetus can utilize ketone bodies as alternative fuel. Glycogen synthesis begins at 9 weeks gestation in the liver, accelerating dramatically during the 3rd trimester. By term, hepatic glycogen stores reach adult levels of 5 to 8% of liver weight. Muscle glycogen accumulation follows a similar pattern. Fat storage occurs predominantly during the last trimester, explaining the limited energy reserves of premature infants. These developmental patterns profoundly impact postnatal glucose homeostasis and risk of hypoglycemia. Birth triggers dramatic metabolic adaptation as maternal glucose supply ceases abruptly. Within minutes, catecholamine levels surge 10 to 20-fold, initiating glycogenolysis and lipolysis. Glucagon concentrations rise 3 to 5-fold, while glucagon receptor sensitivity increases, shifting the glucagon-insulin ratio to favor glucose production. These hormonal changes activate hepatic glycogen phosphorylase, mobilizing stored glycogen. Falling glucose levels stimulate cortisol secretion, inducing gluconeogenic enzymes over several hours. Successful adaptation requires balance between hepatic glucose output through glycogenolysis and gluconeogenesis versus peripheral utilization. Several factors threaten this balance. Limited glycogen stores in premature or growth-restricted infants provide inadequate substrate. Hyperinsulinism from maternal diabetes or stress increases utilization. Hypothermia or sepsis elevates metabolic demands. Enzymatic immaturity may limit gluconeogenesis. Understanding these vulnerabilities identifies at-risk infants requiring glucose monitoring and early intervention to prevent neuroglycopenia. Multiple maternal and neonatal conditions increase hypoglycemia risk, mandating surveillance. Maternal diabetes or glucose intolerance causes fetal hyperinsulinism persisting postnatally. Preeclampsia and hypertension often associate with placental insufficiency and poor glycogen stores. Previous macrosomic infants suggest undiagnosed glucose intolerance. Maternal substance abuse, particularly cocaine, depletes glycogen through chronic stress. Beta-agonist tocolytics stimulate insulin secretion. Oral hypoglycemic agents cross the placenta, causing prolonged neonatal hypoglycemia. Late antepartum or intrapartum maternal glucose administration stimulates fetal insulin, persisting after delivery. Neonatal risk factors include prematurity with limited substrate stores and enzymatic immaturity. Intrauterine growth restriction depletes glycogen and fat reserves. Perinatal hypoxia and ischemia increases metabolic demands while impairing glucose production. Sepsis and hypothermia elevate glucose utilization. Polycythemia increases glucose consumption by the expanded red cell mass. Erythroblastosis causes hyperinsulinism through islet cell hyperplasia. Cardiac malformations increase metabolic demands. Endocrine disorders, including hypopituitarism or adrenal insufficiency, impair counter-regulatory responses. Glucose measurement methods significantly impact clinical decision-making. Point-of-care testing uses reagent strips with glucose oxidase or hexokinase methodology, providing results within minutes. However, these measure whole blood glucose, running approximately 15% below plasma values. Multiple factors affect accuracy. High hematocrit causes falsely low values, while sample hemolysis produces falsely high results. Hyperbilirubinemia and high uric acid interfere with some methodologies. Temperature extremes and improper storage affect reagent stability. Any point-of-care value suggesting hypoglycemia requires laboratory confirmation before treatment. Laboratory measurement on plasma provides definitive values but requires prompt processing. Glycolysis continues in collected samples at 5 to 7% per hour at room temperature. Immediate placement on ice and rapid centrifugation minimize this effect. Some institutions use fluoride-containing tubes to inhibit glycolysis. Understanding these methodologic differences prevents overtreatment based on falsely low point-of-care values, while ensuring true hypoglycemia receives prompt intervention. Hypoglycemia definitions evolved from statistical norms to operational thresholds preventing neurologic injury. Historical definitions used 20 milligrams per deciliter for premature infants and 30 for term infants. Current recommendations suggest maintaining glucose above 45 milligrams per deciliter during the first day, regardless of gestation, increasing to 60 milligrams per deciliter after 48 hours when alternative fuels become less available. Clinical manifestations reflect neuroglycopenia and counter-regulatory responses. Tremors, jitteriness, and exaggerated Moro reflex result from catecholamine surge. High-pitched or weak cry indicates central nervous system dysfunction. Respiratory manifestations include apnea from brainstem effects, tachypnea from metabolic stress, or irregular patterns from disordered control. Cyanosis suggests severe compromise. Lethargy and hypotonia reflect inadequate cerebral fuel. Poor feeding perpetuates the problem. Hypothermia results from inability to maintain thermogenesis. Seizures indicate severe neuroglycopenia, requiring emergency treatment. Many infants remain asymptomatic despite low values, but absence of symptoms doesn't eliminate risk of neurologic sequelae. Asymptomatic hypoglycemia management balances intervention risks against potential neurologic injury. Screen at-risk populations within the first hour. Small for gestational age infants with depleted stores. Infants of diabetic mothers with hyperinsulinism. Large for gestational age infants, often from undiagnosed maternal glucose intolerance. And late preterm infants with immature metabolism. For stable, asymptomatic infants, attempt feeding first. Breast milk or formula provides approximately 7 milligrams per kilogram per minute glucose when feeding 20 milliliters per kilogram. Recheck glucose 1 hour post-feeding. Values below 25 milligrams per deciliter mandate intravenous glucose, despite absent symptoms. For intermediate values between 25 and 40 milligrams per deciliter, consider repeat feeding versus intravenous therapy based on clinical context and trajectory. Dextrose gel represents an emerging alternative. 40% gel at 0.5 millimesos per kilogram massaged into buccal mucosa provides rapid absorption. Combined with breastfeeding, this approach reduces NICU admissions and formula supplementation while supporting breastfeeding goals. Success requires intact swallowing and alert state. Symptomatic hypoglycemia constitutes a medical emergency requiring immediate intravenous therapy. Administer dextrose 10% water at 2 milliliters per kilogram over 1 minute. This provides 200 milligrams per kilogram glucose, raising blood levels by approximately 36 milligrams per deciliter. Avoid more concentrated solutions which cause rebound hypoglycemia from insulin surge. Follow with continuous dextrose 10% infusion, targeting glucose infusion rate of 6 to 8 milligrams per kilogram per minute. Calculate rate using the formula. Rate in milliliters per hour equals 6 times weight in kilograms times desired GIR divided by dextrose concentration. Refractory hypoglycemia despite GIR exceeding 8 milligrams per kilogram per minute requires endocrinology consultation and consideration of adjunct therapies. Hydrocortisone at 5 milligrams per kilogram per day decreases peripheral utilization while inducing gluconeogenic enzymes. Glucagon at 0.1 milligrams per kilogram stimulates glycogenolysis, but depletes stores rapidly. Diazoxide at 5 to 15 milligrams per kilogram per day inhibits insulin secretion. Somatostatin analogs suppress both insulin and growth hormone. Pancreatectomy remains the last resort for severe congenital hyperinsulinism. Hyperglycemia commonly complicates extremely premature infant management, with incidence inversely related to gestational age. Point-of-care values exceeding 120 to 125 milligrams per deciliter or plasma glucose above 150 milligrams per deciliter define hyperglycemia, typically manifesting within the first 3 days. Clinical signs reflect osmotic effects and metabolic derangements. Glycosuria appears when glucose exceeds the Riedel threshold around 180 milligrams per deciliter, causing osmotic diuresis. Dehydration follows from urinary losses. Weight loss accelerates beyond expected physiologic patterns. Fever may indicate dehydration or infection, precipitating stress. Hyperglycemia. Ketosis develops from incomplete glucose utilization. Metabolic acidosis reflects poor perfusion or sepsis. Failure to thrive results from caloric losses in urine. Primary concern centers on hyperosmolarity. Each 18 milligram per deciliter glucose elevation increases osmolarity by 1 milliosmol per liter. Osmolarity exceeding 300 milliosmols per liter causes significant diuresis. Extreme elevations between 450 and 720 milligrams per deciliter create osmotic gradients shifting intracellular fluid outward, potentially precipitating intraventricular hemorrhage through cerebral dehydration and vascular fragility. Hyperglycemia management emphasizes prevention through appropriate initial glucose delivery. Stud glucose infusion rates at 4 to 6 milligrams per kilogram per minute for all infants, lower than traditional recommendations. Monitor glucose every 4 to 6 hours initially, adjusting GIR by 1 to 2 milligrams per kilogram per minute based on trends. Recalculate GIR whenever changing fluid goals, a common error causing inadvertent glucose load increases. For persistent hyperglycemia above 250 milligrams per deciliter, despite GIR reduction to 4 milligrams per kilogram per minute, consider insulin therapy. Start at 0.01 to 0.05 units per kilogram per hour, titrating carefully. However, routine prophylactic insulin shows no benefit. Studies demonstrate increased hypoglycemic episodes without improving mortality, growth, or neurodevelopment. Reserve insulin for symptomatic hyperglycemia with osmotic diuresis or inability to provide adequate nutrition due to glucose intolerance. Always exclude sepsis before attributing hyperglycemia to immaturity alone. Parenteral nutrition provides essential nutrients when enteral feeding remains impossible or inadequate. Primary goals include preventing energy and protein deficits during critical developmental periods while promoting appropriate weight gain and growth. Early initiation prevents cumulative nutritional deficits. Every day of inadequate nutrition in extremely premature infants correlates with worse neurodevelopmental outcomes. Very low and extremely low birth weight infants universally require parenteral nutrition due to immature gastrointestinal function and limited reserves. Surgical conditions like gastroschisis, tracheoesophageal fistula, or necrotizing enterocolitis mandate bowel rest. Renal failure may preclude adequate enteral protein delivery. Critically ill-term infants often cannot tolerate enteral feeds during acute illness. Initiation within the first 24 hours, particularly amino acids, prevents negative nitrogen balance and promotes anabolism. Access route depends on anticipated duration and solution composition. Peripheral for short-term with appropriate osmolarity limits. Central for extended support or concentrated solutions. Parenteral nutrition access requires careful consideration of duration, solution composition, and complications. Peripheral access suffices for short-term support under 7 days using solutions with dextrose concentrations at or below 12.5%. Osmolarity must not exceed 900 milliosmoles per liter to prevent phlebitis and infiltration injury. Calculate osmolarity by summing contributions. Each percent dextrose adds 50 milliosmoles. Each milliequivalent of electrolyte adds 1 milliosmole, and amino acids contribute approximately 100 milliosmoles per percent. Central access becomes necessary for extended support, higher dextrose concentrations, or hyperosmolar solutions. Umbilical venous catheters provide immediate access but carry infection risk with prolonged use. Peripherally inserted central catheters offer longer-term access with lower infection rates. Light protection throughout the system prevents vitamin degradation and lipid peroxidation. Photosensitive vitamins, particularly vitamin A, degrade rapidly with light exposure. Lipid emulsions generate harmful peroxides under light, potentially contributing to chronic lung disease and retinopathy of prematurity. Parenteral nutrition requires lower caloric targets than enteral feeding due to absent fecal losses and reduced thermogenesis. Aim for 80 to 100 kilocalories per kilogram per day parenterally, compared to 110 to 140 enterally. Extremely preterm infants need the higher range to support growth approximating intrauterine rates of 15 grams per kilogram per day. Non-protein calories should provide energy, sparing amino acids for protein synthesis. Fluid goals vary with gestational age initially, but target 100 to 150 milliliters per kilogram per day by day 5 to 6. Accurate caloric calculations guide prescription adjustments. Carbohydrates from dextrose provide 3.4 kilocalories per gram. Multiply milliliters per day times 3.4 times percent dextrose divided by 100. Enteral feeds vary by type, but typically provide 20 to 24 kilocalories per ounce. Lipids at 20% concentration provide 2 kilocalories per milliliter, while 10% provides 1.1 kilocalories per milliliter. Amino acids provide 4 kilocalories per gram, but should support growth, not energy needs. Dextrose provides the primary carbohydrate source in parenteral nutrition, requiring careful titration to prevent both hypoglycemia and hyperglycemia. Initial glucose infusion rates of 4 to 6 milligrams per kilogram per minute prevent hypoglycemia while avoiding hyperglycemia in extremely premature infants. advance by 1 to 2 milligrams per kilogram daily toward goals of 11 to 12 milligrams per kilogram per minute, providing adequate calories for growth. Standard concentrations range from 5 to 10%, though higher concentrations up to 12.5% may be used peripherally with caution. Remember that every 1% dextrose equals 1 gram per deciliter or 10 grams per liter. With caloric density of 3.4 kilocalories per gram, dextrose efficiently provides energy. Master GIR calculations for bedside adjustments. GIR equals dextrose percent times milliliters per kilogram per day, divided by 144. The alternative formula, GIR equals dextrose concentration times rate in milliliters per hour, divided by 6 times weight in kilograms, proves useful for pump settings. Accurate calculations prevent inadvertent glucose loads when changing fluid rates. Protein delivery prevents negative nitrogen balance and supports growth, with requirements inversely related to gestational age. Extremely preterm infants need 3.5 to 4 grams per kilogram per day to match intrauterine accretion rates. Late preterm and term infants require 2.25 to 3 grams per kilogram per day. Early initiation proves critical. Start 2 to 3 grams per kilogram per day from day 1 for very low and extremely low birth weight infants. This prevents the catabolic state that develops within hours of birth without amino acid supply. Advance by 0.5 to 1 gram per kilogram daily toward goal. Maximum delivery reaches 3 grams per kilogram per day for term infants or 4 grams per kilogram per day for preterm infants. Higher amounts increase azotemia without improving growth. Modern crystalline amino acid solutions provide appropriate profiles for neonates, including conditionally essential amino acids like cysteine, tyrosine, and taurine. Lipid emulsions provide essential fatty acids and concentrated calories in parenteral nutrition. Recent evidence supports early, aggressive lipid supplementation. Start 2 grams per kilogram on the first day for infants under 1,500 grams, advancing to 3 grams per kilogram on day 2. Extremely low birth weight infants may require slower advancement monitoring triglyceride clearance. Continuous infusion over 24 hours optimizes clearance compared to shorter infusion times. Essential fatty acid deficiency develops within days without supplementation. As little as 0.5 to 1 milliliter per kilogram per day of 20% emulsion prevents deficiency. 20% solutions at 2.2 kilocalories per milliliter provide more efficient delivery than 10% solutions. Specialized formulations address parenteral nutrition-associated liver disease. Omegaven, pure fish oil emulsion high in omega-3 fatty acids, may reverse cholestasis. SMUF combines soybean, medium-chain triglycerides, olive, and fish oils, potentially reducing inflammatory responses. These alternatives require special protocols, but offer options for infants developing hepatic complications. Electrolyte supplementation in parenteral nutrition requires careful timing and anything to compatibility. Withhold sodium and potassium during the first 24 hours to allow physiologic transitions. After 24 to 48 hours, provide sodium at 2 to 3 milliequivalents per kilogram per day and potassium at 1 to 2 milliequivalents per kilogram per day after confirming adequate urine output. Calcium requirements begin immediately at 20 to 60 milligrams per kilogram per day of elemental calcium, increasing to 60 to 80 milligrams per kilogram per day for bone mineralization. Note that calcium gluconate contains 9% elemental calcium. 100 milligrams of calcium gluconate provides 9 milligrams elemental calcium. Phosphorus supplementation starts day 2 at 45 to 60 milligrams per kilogram per day. Maintain calcium to phosphorus ratio of 1.7 to 1 by weight or 1.3 to 1 by molar ratio to optimize solubility and prevent precipitation. Adding cysteine lowers solution pH, improving calcium phosphorus solubility while providing conditionally essential amino acid. Magnesium at 0.25 to 0.5 milliequivalents per kilogram per day supports enzymatic functions and bone health. Vitamin and trace element supplementation prevents deficiency states during exclusive parenteral nutrition. MVI Pediatric provides water and fat-soluble vitamins dosed by weight. 2.5 milliliters daily for infants under 2.5 kilograms, 5 milliliters for larger infants. Light protection prevents vitamin A degradation. Trace elements should begin within the first few days, providing selenium for antioxidant function, copper for ceruloplasmin synthesis, chromium for glucose metabolism, zinc for growth and immunity, and other essential minerals. Iron supplementation typically awaits establishment of enteral feeding to minimize oxidative stress. Carnitine at 10 mg per kilogram per day facilitates fatty acid transport into mitochondria for oxidation. Endogenous synthesis may be inadequate in premature infants. Cysteine serves dual purposes. Providing substrate for taurine synthesis is essential for neurodevelopment and bile acid conjugation, while lowering solution pH to improve calcium-phosphorus solubility. These additions optimize the nutritional completeness of parenteral solutions. Parenteral nutrition carries significant risks, requiring vigilant monitoring and prevention strategies. Central line mechanical complications during insertion include pneumothorax from pleural puncture, hemothorax from vascular injury, air embolism during catheter manipulation, and cardiac perforation from advancement into right atrium. Radiographic confirmation of proper position before use remains mandatory. Line-related complications develop over time. Malposition into inappropriate vessels, occlusion from precipitation or thrombosis, venous thrombosis potentially causing superior vena cava syndrome, spontaneous migration requiring repositioning, and phlebitis from hyperosmolar solutions. Daily evaluation of insertion site, catheter function, and radiographic position prevents serious sequelae. Central line-associated bloodstream infections represent the most common serious complication. Implementation of insertion bundles, including maximal barrier precautions and maintenance bundles with proper hub hygiene, reduces infection rates by 70%. Dedicated vascular access teams further improve outcomes. Long-term complications include cholestasis from parenteral nutrition-associated liver disease, potentially progressing to cirrhosis. Osteopenia results from inadequate mineral delivery and aluminum contamination. Peripheral extravasation causes severe tissue necrosis, requiring plastic surgery intervention. Parenteral nutrition carries significant risks, requiring vigilant monitoring and prevention strategies. Central line mechanical complications during insertion include pneumothorax from pleural puncture, hemothorax from vascular injury, air embolism during catheter manipulation, and cardiac perforation from advancement into right atrium. Radiographic confirmation of proper position before use remains mandatory. Line-related complications develop over time. Malposition into inappropriate vessels, occlusion from precipitation or thrombosis, venous thrombosis potentially causing superior vena cava syndrome, spontaneous migration requiring repositioning, and phlebitis from hyperosmolar solutions. Daily evaluation of insertion site, catheter function, and radiographic position prevents serious sequelae. Central line-associated bloodstream infections represent the most common serious complication. Implementation of insertion bundles, including maximal barrier precautions and maintenance bundles with proper hub hygiene, reduces infection rates by 70%. Dedicated vascular access teams further improve outcomes. Long-term complications include cholestasis from parenteral nutrition-associated liver disease, potentially progressing to cirrhosis. Osteopenia results from inadequate mineral delivery and aluminum contamination. Peripheral extravasation causes severe tissue necrosis, requiring plastic surgery intervention. Practical fluid calculations translate management principles into bedside orders. Total daily fluid equals weight in kilograms multiplied by fluid goal in milliliters per kilogram per day. For a 2-kilogram infant requiring 120 milliliters per kilogram per day, 2 times 120 equals 240 milliliters daily. Convert to hourly rate by dividing by 24. 240 divided by 24 equals 10 milliliters per hour. When combining enteral and parenteral fluids, subtract enteral volume from total goal. If the same infant tolerates 60 milliliters enteral feeds, 240 minus 60 equals 180 milliliters intravenous fluids daily, or 7.5 milliliters per hour. For replacement of excessive losses, monitor urine output exceeding 6 milliliters per kilogram per hour. Replace with 0.2% normal saline, quarter normal saline to avoid sodium overload while maintaining volume. Calculate replacement based on actual excess. if urine output measures 8 milliliters per kilogram. This comprehensive review covered 10 critical areas consistently tested in neonatal boards and essential for clinical practice. Understanding developmental physiology explains why management strategies vary with gestational age. Total body water composition changes guide expected weight loss patterns and fluid requirements. Factors modifying insensible water loss enable individualized prescription. Initial fluid goals prevent both dehydration and overhydration during transition. Appropriate electrolyte supplementation timing prevents dangerous imbalances. Systematic approaches to electrolyte abnormalities ensure safe correction. Glucose homeostasis management prevents both acute injury and long-term sequelae. Parenteral nutrition knowledge enables optimal growth support. Acid-base interpretation guides ventilatory and metabolic interventions. Mastery of these concepts, combined with careful clinical assessment and calculation skills, provides the foundation for expert neonatal fluid and electrolyte management. Remember, this remains an art, requiring daily reassessment and individualization based on the whole clinical picture. These clinical pearls distill decades of neonatal intensive care experience into practical guidance. Initial laboratory values before 10 to 12 hours reflect maternal physiology through placental equilibration. Avoid unnecessary interventions based on these results. Daily weights provide the earliest and most sensitive indicator of fluid balance, detecting changes before clinical signs appear. Extremely premature infants may maintain urine output despite significant dehydration due to tubular immaturity. Don't rely solely on urine output. Withholding sodium supplementation for 24 to 48 hours allows physiologic contraction. 2 emergency scenarios demand immediate action. Seizures with hyponatremia require 3% saline, while wide QRS complexes with hyperkalemia mandate the CBIG-2 protocol. Always question elevated potassium results. Hemolyzed samples commonly cause false elevations. Trends matter more than isolated values. The clinical picture guides interpretation. Gradual corrections prevent catastrophic shifts. Cerebral edema with rapid sodium correction. Osmotic demyelination with slow correction. Peripheral parenteral nutrition osmolarity exceeding 900 milliosmoles per liter causes phlebitis and infiltration injury. Glucose infusion rate calculations with every change prevent inadvertent hyperglycemia. Chronic diuretic therapy depletes multiple electrolytes, requiring systematic monitoring. These pearls, combined with thorough understanding of physiology, enable safe and effective management. An infant with sodium deficiency would demonstrate dysrhythmia, muscle weakness, poor growth. The correct answer is poor growth. Sodium deficiency in infants primarily manifests as poor growth and failure to thrive. Sodium is essential for cellular function, fluid balance, and metabolic processes that support normal growth and development. Why the other choices are incorrect: muscle weakness. While possible with severe sodium deficiency, this is not the primary manifestation in infants and is more commonly associated with potassium or calcium imbalances. Dysrhythmia. Cardiac dysrhythmias are typically caused by potassium, calcium, or magnesium disorders, not sodium deficiency. Poor growth serves as an early and sensitive indicator of chronic electrolyte imbalances in infants, making it the most characteristic presentation of sodium deficiency. An extreme preterm infant develops peaked T waves, widened QRS complexes, and flattened P waves on ECG. The first step in management should be administer furosemide to promote potassium excretion. Administer insulin and glucose to shift potassium intracellularly. Calcium gluconate. 1 to 2 milliliters per kilogram IV over 15 to 30 minutes. The correct answer is calcium gluconate. 1 to 2 milliliters per kilogram IV over 15 to 30 minutes. The ECG findings of peaked T waves, widened QRS complexes, and flattened P waves are characteristic of hyperkalemia with cardiac manifestations. Calcium gluconate is the first-line treatment because it immediately stabilizes cardiac membranes and counteracts the effects of hyperkalemia on cardiac conduction, providing rapid protection against life-threatening arrhythmias. Where the other choices are incorrect. Furosemide. While furosemide can promote potassium excretion, it takes longer to work and may worsen fluid electrolyte imbalances in preterm infants. It's not the immediate priority when ECG changes are present. Insulin and glucose. This combination effectively shifts potassium intracellularly and is an important second-line treatment, but it doesn't provide the immediate cardiac membrane stabilization needed when ECG changes indicate imminent cardiac risk. The key principle is that when hyperkalemia presents with ECG changes, cardiac membrane stabilization with calcium gluconate takes priority over interventions that actually lower potassium levels, as it provides immediate protection while other treatments take effect. Calculate the glucose infusion rate, GIR, for a 1.2 kilogram infant receiving D10W at 5 milliliters per hour. 4.8, 6.9, 8.3. The correct choice is 6.9 milligrams per kilogram per minute. This question is testing your ability to calculate glucose infusion rate, a critical skill in neonatal fluid management. The calculation is GIR equals D times rate divided by 6 times weight equals 10 times 5 divided by 6 times 1.2 equals 50 divided by 7.2 equals 6.9 milligrams per kilogram per minute. 4.8 and 8.3 are incorrect due to a calculation error. An arterial blood gas for a ventilated preterm infant shows pH 7.25, PaCO2 60 millimeters mercury, PaO2 65 millimeters mercury, HCO3 minus 24 milliquibbles per liter. This represents metabolic acidosis with respiratory compensation, respiratory acidosis without compensation, respiratory alkalosis with metabolic compensation. The correct choice is respiratory acidosis without compensation. This question is testing your ability to interpret acid-base disorders from blood gas values. Metabolic acidosis with respiratory compensation is incorrect because the bicarbonate is normal, indicating no metabolic component. Respiratory alkalosis with metabolic compensation is incorrect because the pH is acidotic, 7.25, with an elevated PaCO2, 60 millimeters mercury, which is consistent with respiratory acidosis, not alkalosis. A 3-day-old ELBW infant has a serum sodium of 128 with signs of volume depletion. The most appropriate management is fluid restriction to normalize serum sodium, provide sodium supplementation and replace fluid deficit, sodium bicarbonate administration. The correct choice is provide sodium supplementation and replace fluid deficit. This question is testing your understanding of hyponatremia management based on volume status assessment. Fluid restriction to normalize serum sodium is incorrect because this would be appropriate for hyponatremia with normal or excess ECF volume, as in SIADH, not with volume depletion. Sodium bicarbonate administration is incorrect because it addresses acidosis rather than hyponatremia and could worsen the infant's condition if not indicated.